Thank you. Well, I thank Dr. Bansi for involving me in this wonderful academic feast. And we have Dr. Harit Buch, who is pretty well known. He is a current and his responsibility is a SAS tutor and clinical supervisor for foundation trainees. And well, his reasons for being mentor is he's impressed with the program, he's keen to impart knowledge and experience, and he's keen to interact with new and young consultants. His specific areas of professional interest are endocrinology and inpatient diabetes. And the first year he appointed as a substantive counsel was in 2002. So he's from UK. So it's my great pleasure to invite Dr. Harit Buch, who is going to talk on a subject which is not routinely touched upon. And that's why I'm very looking forward with a lot of excitement about diabetes and bone. Dr. Harit Buch. Harit, you'll have to unmute yourself.
Yeah, I think I hadn't unmuted myself, and I hadn't unmuted the video for the system both. I hadn't spoken anything, but I'm struggling to share the screen because it says somebody else. Okay. I think it will let me do it now. Is that?
It is seen now. It is seen now.
Okay. Thank you very much for inviting me to this talk and to the organizing committee, and particularly to Banshi Sabu. However, I have to say that the gratitude that I feel for Banshi has been significantly diluted by the topic that he has given me. It is one of those topics which is probably the one quite lacking in evidence, maybe lacking in interest for a lot of people. So I think, Banshi, thank you very much for giving me this topic. However, I have to say the other issue is that I'm not involved in diabetes to a large extent. But my involvement with bone is mainly through our joint clinics with rheumatology for management of endocrinological osteoporosis and primary osteoporosis. So in the United Kingdom, the osteoporosis comes under the purview of rheumatology and in some places endocrinology, like at our center. I work in a large district general hospital called New Cross Hospital in a place called Wolverhampton, not too far from. And the most famous part of Wolverhampton is the football club, which is symbolized by the little logo at the left bottom corner of my slide, which is Wolverhampton Wanderers. So that's the only interesting bit of my talk, I think. But I shall try my best to give you some information that is out there. So I'm going to answer some of these questions. Does diabetes increase fracture risk? If it does increase fracture risk, in which particular subgroups? What is the mechanism? Which of these patients need treatment, and with what particular agents? And this is my biggest disclaimer, is that there is very little evidence which is robust, very few prospective or even controlled trials. And most of the conclusions that everyone, including myself today, have drawn are from observational and epidemiological data. So compared to the kind of data that was presented previously, this is not going to be that sort of information. But a lot of these studies have been published, performed in a large number of patients. So there are some safe conclusions we can safely draw. So with that background, now the background of the topic, I mean, these are the things which we definitely know, and it's not controversial. We all know that the age of the population is rising. We all know that osteoporosis is commoner in older individuals. The risk of osteoporosis goes up, with osteoporosis goes up the fracture risk. And I think we all know, but probably is not well known enough, is that a fracture is a serious health risk. So a person with hip fracture, 1 in 10 die in 1 month, and up to 3 out of 10 die in 1 year. And in addition to this, it also leads to a significant degree of morbidity and functional impairment, which in turn has a significant impact on the care arrangements, especially in the Western world. What we also know, and I'm sure all of you would agree in this audience, is that thanks to the efforts of a lot of people working in diabetes, the average age of survival age of both type 1 and type 2 diabetes is getting longer. And we have a lot of people who are old and have diabetes. So then if you put all these facts together, and then if diabetes increases fracture risk, you can imagine the magnitude of the task ahead of all of us in terms of fracture population. So the question is, does diabetes increase the fracture risk? I'll just start off with a couple of papers, very brief. Well, one of them, a 78-year-old lady with a long-standing type 1 diabetes, no other relevant known osteoporosis risk factors, and these are the ones that are in the FRAX risk score, you would know, with a DEXA scan result, which I think is quite acceptable, at least at the hip for a 78-year-old lady, ends up having a hip fracture 2 years after DEXA scan. And that just goes to show how these conventional factors could not predict hip fracture. This lady ended up with incomplete recovery of mobility and in a care home. The other patient was a 66-year-old man, having had diabetes for half of his life, but had no risk factors for osteoporosis or for fracture, has hypoglycemia, has a fall, has a hip fracture, admitted to hospital, 3-month stay with post-operative sepsis and delayed recovery. He did recover fully, but after a lot of morbidity. So I think these sort of patients are well known to a lot of you. Both these people had hip fracture despite their overall risk profile in the conventional sense being below the intervention threshold. And this particular story is, I have to say, not exclusive for diabetes, because bone density is not that great at its sensitivity in picking up fracture risk, but it's certainly very typical of people with diabetes. So if we look at type 1 diabetes, and there is a very large meta-analysis published about 4 or 5 years ago now, where you can clearly see that the fracture risk has a statistically significant increase in compared to background population. And this is actually seen in a number of these smaller studies which constituted this meta-analysis. So I think there seems to be a convincing evidence for an increase in fracture risk in type 1 diabetes. The same can be seen, but if you look across on this table in the top row of type 1 diabetes, you can see a significantly high odds ratio for any fracture, for vertebral fracture or for hip fracture. But what you can also see that the evidence is not so robust in type 2 diabetes. There isn't really convincing data on vertebral fracture risk. There are some people who have shown higher risk. There are others who have shown that it's not increased. But the hip fracture risk is generally considered to be statistically significantly higher in people with type 2 diabetes. I'm sorry, I haven't put down the confidence interval there, but it is significant. So I think even in type 2 diabetes, hip fracture risk is higher. So in conclusion, the fracture risk is higher in individuals with type 1 diabetes and to a lesser extent in patients with type 2 diabetes. And then if you throw in other important bits of information, that hip fracture tends to occur in patients with diabetes 10 to 15 years earlier than what happens in non-diabetes individuals. And the outcomes of the patients having had fracture is also worse in individuals with diabetes. And both of these things were actually nicely illustrated in the two patients that I presented. So with all these bits of information, if you throw it into a pot, I think it clearly shows that there is a significant challenge for all of us in this relatively new aspect of diabetes and the implications of having diabetes on bone health. Now, clearly, we need to do something for this. We can't do something for everybody. So not every person of diabetes would need management. And therefore, we need to identify those who are at the greatest risk. So if you look at the age distribution, although the increasing age increases the risk, if you look at the youngest group of these four cohorts, they have the highest relative risk as compared to background population. And the reason for this is not difficult to understand, because these younger individuals have a very low risk profile outside the diabetes sphere. And as they grow older, the risk of the background population goes up, and therefore the ratio comes down. So I think the risk does go up with increasing age, but as a diabetes specific issue, the younger individuals are the ones where the difference is the most stark, and possibly in males. Those who have a longer duration of diabetes are at greater risk. But the association with glycemic control is rather murky. It isn't really clear as to whether the two are linked, but certainly in type 1 diabetes, it has been shown that worse the control, the more likely is the fracture. There is no clear cutoff which has been identified, but there is one study which separates patients across the target of 7%. One would expect diabetes complications to be a factor. So it's not surprising that those who have microvascular complications have higher risk, but nephropathy is the only complication which has been independently defined as a predictor for fracture risk. The rest of them may have other confounding factors. So in brief, it's the people with long-term diabetes, those with poor control possibly, and certainly those with microvascular complications. And these are the people whom we should be probably targeting. What about the drugs which are used for diabetes? And I think you can probably guess that in the ones in green zone, the metformin and the incretin drugs, they have a neutral impact on fracture risk, mainly because through various mechanisms that seem to be leading to bone formation. And that sort of brings up the effect to be neutral or maybe slightly positive. However, insulin and sulfonylurea are being shown to increase the risk. No mechanistic explanation in terms of effect on bone, and this impact on fracture risk seems to be largely derived from the other actions of insulin, i.e. causing hypoglycemia and falls. It is also important to remember that the patients who are chosen for insulin are de facto higher risk group patients, so they're older with comorbidity. On the other hand, thiazolidinedione is shown to have a direct effect on bone through these PPAR gamma agonist effect, reducing to some extent the osteoblastic function and reducing bone formation. The one I have left blank is the Sglt2 inhibitor. These are the newest kids on the block for diabetes patients, and they seem to be doing almost everything. I'm actually surprised they are not being used as anti-COVID drugs. But what the impact on the bone is interesting, because the initial impression was certainly formed on the basis of this particular study called CANVAS, which looked at the impact of canagliflozin on cardiovascular outcomes and its benefit in those patients, where there was a clear difference. I must remember to use the arrow. So there's a clear difference here where CANVAS show increases the fracture risk. While what is also noticeable is that all the other non-canvas canagliflozin studies, there was no statistically significant impact on bone risk, on fracture risk. So what could be the mechanism? Well, one of the mechanisms floated is that once the kidneys try and lose glucose, the phosphate is retained and that raises the PTH level. So that then leads to increased fracture risk. However, one has to focus on these factors, and that to a large extent mitigates the impact of canagliflozin. So if you look, most of the fractures in this particular study happened in the first 1 or 2 years of its use, and it's very unlikely that a direct effect on bone could be responsible. It's much more likely, although hypothetical, that it's the volume depletion effect and leading to falls that could have caused these fractures. Also, these people had a higher cardiovascular risk, higher use of diuretics, all these factors predisposing to adverse bone outcomes. And when the fractures did happen, they happened in the non-spine, non-hip areas. And this support for the use of Sglt2 inhibitors is then brought out by several other meta-analyses which have been published subsequent to the Canvas study, which have all shown that none of these drugs have a statistically significant impact on the fracture risk when used with metformin. So all these 4 groups were using metformin and compared with other oral agents for fracture risk, and none of them had a significant impact. But even within this, you can see canagliflozin had the highest odds ratio. So I think in conclusion with the Sglt2 inhibitors, one can probably say that common sense would guide you to avoid canagliflozin in patients who have a very high bone risk or fracture risk, at least until further data is available. So the next question is, how does diabetes affect fracture? Is it through bone density? Well, the bone density is certainly reduced in type 1 diabetes, but then you find that the fracture risk is disproportionately high to the degree of reduction of bone density. And also in type 2 diabetes, the bone density is in fact higher than in, excuse me, higher than in background population. Especially if you look in people who are younger and those who are obese with type 2 diabetes. So if bone mineral density cannot explain the fracture risk, what are the other factors that are contributing or causing fracture risk to go up? Excuse me. So the focus actually squarely falls on something called microarchitectural quality of the bone. And this is a very well-known factor which also is responsible for fractures in several other situations along with bone density. And in population with diabetes, there is a lot of evidence based on rather sophisticated analysis of the bone through MRI, through volumetric bone mineral density, and biochemical markers assessing the advanced glycation end products, which all point to poorer architecture of the bone. One of the methods which can be used more routinely rather than these relatively less used methods is that of the trabecular bone strength, which can be measured off a DEXA image. And it has been clearly shown that if you use TBS in place of bone density, you can predict fracture risk much better in type 2 diabetes. And this again squarely puts the blame on microarchitectural changes in the bones. Some evidence also that the bone turnover is reduced, but not convincing enough to say that the osteoblastic function is disproportionately reduced. But the bone markers, the biochemical markers for bone turnover are all reduced, both for bone formation and for bone resorption. However, in the midst of all this noise, one thing which we should not forget is the increased risk of falls in people with diabetes. Now, I think you will hardly ever hear falls to be at the front line of all the publications because none of the pharmaceutical companies produce anything to reduce falls. But falls is one of the strongest factors in causing fractures in elderly population. And if you think of the population with diabetes, especially the older population, there are significant factors that can drive falls. So hypoglycemia, the muscle and neuromuscular changes, other complications like visual impairment, and the presence of comorbidity. So I think falls prevention should probably get a lot more focus than what it usually receives. However, if you look at purely from a bone point of view, microarchitecture is the guilty party. So then the next question is, what can we do and in which patients? And I think it's the second question that is more important to discuss. Which are the patients with diabetes? How can you decide in an individual person whether to intervene or not to intervene? The worrying feature is if you go by the standard criteria, you're going to significantly underestimate the risk of fracture. And you can see that in this is a very nice study on a large number of people where it was clearly shown that for the same standard deviation of -2.5, the gap between these two red lines clearly shows the difference in fractures. So if you use the -2.5 as the standard cutoff, you will underestimate fracture risk. The dotted line is for people with diabetes and the continuous line for non-diabetes population. And the same applies to this one here, where the FRAX risk score is being used, and the same gap can be seen in the perceived risk and the actual risk. So it is not enough to use conventional criteria for making a decision on intervention. So what can we do? Well, 3 additional factors have been suggested. You can use one of these 3. So you could consider diabetes in place of rheumatoid arthritis on the FRAX calculator. Excuse me. So I think a lot of you may be familiar with the FRAX risk calculator. Rheumatoid arthritis deserves a tick. So the diabetes can be used in place of rheumatoid arthritis, both type 1 and type 2. Or you can add 10 years to the patient's age, or you can reduce the t-score by 0.5. So if the t-score is -2, then use -2.5. And in this particular study from Canada, it was very nicely shown that all these 3 factors are reasonably successful in predicting fracture risk in diabetes population, certainly much more than using conventional criteria. So, and all these are relatively straightforward criteria, which all of us can use in our offices. One thing I would like to emphasize, though, is whilst DEXA and t-scores, DEXA and FRAX are not useful to decide in the intervention on conventional basis, once you decide the threshold, within population, DEXA and FRAX are equally useful in diabetes groups. So to decide escalation of treatment, response to treatment, follow-up of patients, to assess the gradient of risk for all these factors, DEXA and FRAX are equally useful in diabetes as in non-diabetes. It's just in the intervention threshold that you need to modify. So this is a quick summary of what I've just said. In groups of people with diabetes, if they have fractured, give them treatment like we usually do. But if they have these diabetes-related clinical risk factors, with or without other risk factors, then you can either use a DEXA scan using a t-score of -2, or you can use FRAX score independent or with DEXA using diabetes as rheumatoid arthritis and adding 10 to the age. And if they then meet intervention threshold, you treat them. If they don't, just follow them up every 2 to 3 years like you'll do for any other patient group. Well, after all that, what do we do for these patients? Well, we give them lifestyle measures. What constitutes lifestyle measures? Well, the usual stuff: don't smoke, don't drink. Well, I can't say don't drink. I'm from the state of Gujarat. That's why I say don't drink. But I think you're allowed to drink less than 3 units, but not always advisable. One thing you need to be careful is when you advise people with diabetes to lose weight, as far as possible, advise them to do weight-bearing exercise. Because many people believe that this significant weight loss, which a few people do achieve, can adversely affect the bone health in a short-term sense. So if they exercise along with weight loss through dietary measures, that would be a good mix, which is usually the case for anybody, but particularly for bone health. Maintain vitamin D above 75 nanomole per liter, optimize glycemic control, which is, as we saw earlier on, it's quite easy. Give them combination treatment and avoid incriminating diabetes therapy wherever possible. Now, what specific treatment agent? Well, this is where the fundamentals of this talk is weak, because I have nothing new to say in terms of what agents to use. Because it was believed that the very mechanism of adverse bone health being more in terms of microarchitecture than bone density, the drug use will be probably different, but it isn't, because all this data derived from post hoc analysis of osteoporosis trials for non-diabetes patients shows the same thing as what is shown in diabetes individuals. Use oral bisphosphonates. You can use raloxifene. We don't use it particularly here in the UK. But both of them increase bone density, both of them reduce fracture risk, just like any other diabetes population, despite grave theoretical constraints, because there is no bone, these drugs are anti-resorptive agents, but it does increase bone density, and maybe that's why the reduced fracture risk. There is no evidence for intravenous bisphosphonates, but there is no reason to believe it won't work. Again, same with denosumab, which is being used increasingly in this country. Teriparatide, an expensive drug, which logically, for a microarchitectural pathology and one which has reduced bone turnover, should be a dream drug, but it has not been shown to be significantly more effective, although there is hardly any work, serious work being done on this so far. And nor is there enough evidence to recommend any of the newer agents which are not particularly been used so far in any case. So the advice is use a diabetes-specific intervention threshold and then treat like any other non-diabetes person. And that's all I have to say. And I would just conclude by saying that the fracture risk is high, discordant to bone mineral density. So don't only rely on the bone mineral density. The risk appears to be higher in the kind of people we would expect it to be higher: long-standing, poorly controlled diabetes, complications. Intervention threshold is the key. Use any of the 3 criteria that I mentioned, but probably using diabetes in place of rheumatoid arthritis seems to be the most logical one. And there is a little bit of work we are doing on the cost analysis on using each of these 3 criteria. Hopefully in future we'll be able to come up with the answer for that. And the last thing to say is that the treatment options are rather similar for people with diabetes as those without diabetes. And I'll stop there. Thank you.